Hello there, doctors. Welcome to the Triage Notes. Today, we are going to look into something that's rather very simple, but usually people get confused a lot. People stumble upon questions or scenarios where they are actually not able to apply what they have learnt it in a very good uh, manner. So, we are going to look into this topic in a perspective of how this can be applied on day to day life, and at the same time, how we can score a bit in the exams that are coming up. So we are going to look into blood banking and transfusion medicine, and without wasting further time, let's start digging. So before starting the topic per se, I'd like to tell about people who can actually donate blood. The thing is, to store blood and to transfuse, you need blood, and we get blood by blood donation. You might have come across camps and all that where we are collecting blood from people. So people from 18 to 65 years of age can donate blood, and males are usually expected to donate blood every 3 months once, and females can donate blood every 6 months once. And there is actually a cutoff of hemoglobin and weight, which is as written here, it's 12.5 gram percentage, and weight must be greater than 45 kilograms. Right. So now we have known who can donate blood. Then after who, you're going to screen the patient or the person. Right. So once you have known who is supposed to donate blood, you're going to screen that person for a set of diseases. Those diseases will be hepatitis B and C, HIV, syphilis, and malaria. These must be screened for in a person who is going to donate blood. And very specifically, this has been asked as a trivial question in every other medicine setup that I have ever known of, and usually this also pops up as a question in the competitive exams. Malaria is the only disease that can be transmitted by all the blood products. I mean, among the diseases that we screen for, this is the disease that can actually be transmitted in all the blood products, like let it be PRBC, let it be cryoprecipitate, let it be the platelets. We'll look into the blood products separately below, but just a heads up. And how much is the blood that we are going to collect from these patients? So we are going to get 350 ml. The range is actually set between 350 to 450 ml, but usually 450 ml of blood is collected for component separation. This can also pop up as a question at times. How much is the volume of the pouch in which component separation of blood is collected? So it's 450 ml, but 350 ml is supposed to be the normal value. And now the blood is collected. All right, the patient came, you saw from whom you're going to collect, you screened the patient, you figured out how much is the blood that is supposed to be collected, and the blood is now collected. So how are you going to preserve that blood? Usually PRBC is preserved with anticoagulants, right? Because logical sense, if you are not going to add anticoagulants, the blood is going to get coagulated, and these anticoagulants are actually going to determine the expiry date of the PRBC. So there are three anticoagulants. It's very simple to remember this way. It's CPD, CPDA, and SAGM. See guys, we are going to just learn each letter, and that's all. It will be very simple that way, right? So let's start with CPD. CPD stands for citrate, phosphate, and dextrose, right? Here, citrate is going to act as anticoagulant, phosphate is going to act as buffer, and dextrose is going to act as the nutrition. Always and always remember, 99% of the time in medicine, wherever you're going to see phosphate, it is usually going to act as buffer, all right? Not always, but 99% of the time, phosphate is going to be a buffer in every other scenario, right? Then comes CPDA. Already we saw CPD, citrate, phosphate, dextrose, and A is an addition here, which is adenine. Now, the last one comes as SAGM. SAGM stands for sodium, adenine, glucose, and mannitol. Alright, so now these three different anticoagulants have three different expiry dates. Starting with CPD, it's 21 days of preservation, and CPDA helps with 35 days of preservation, and SAGM helps with 42 days of preservation. Mind you guys, all these are only for PRBC, right? PRBC stands for packed red blood cells. So moving forward, Now we have separated the blood products, right? We have gotten the blood products. Now we have learned how these are preserved, like PRBC, they are preserved with the use of anticoagulants. Now the blood is collected, and now we are going to look into the different blood products that we have. One is the whole blood, which contains packed red blood cells. This is followed by fresh frozen plasma, that is followed by cryoprecipitate, and that is followed by random donor platelets, and we have single donor platelets. All right, now we are going to look into this in three parts. One is the volume, second is the temperature, the third is the storage or viability. All right, so now let's start with volume of the whole blood, which is going to be 350 ml, which we already discussed. The storage temperature is 2 to 6 degree centigrades. Remember, it's 2 to 6, not in minus, because in minus things get what? It gets freezed, right? So the whole blood is 350 ml in volume, stored in temperature of 2 to 6 degrees centigrades, and then as discussed here, CPD, CPDA and SAGM, it has variable viability, which is 21 days, 35 days and 42 days, followed by fresh frozen plasma, which is FFP. It is collected and stored in a manner of 200 ml, stored in minus 30 degrees centigrade. See, fresh, frozen. Frozen is below 0 degrees centigrade, right? So we are going to have the temperature as minus 30 degrees centigrade, and we can store it for 1 year, right? Followed by we have cryoprecipitate. Cryoprecipitate is rich in factor 8, factor 13 and 1 Willebrand factor. I usually remember it has three factors, 8, 13 and V, which is one's factor. So it's 8, 13 and 1 Willebrand's factor. It is also rich in fibrinogen. It usually is present in 10 to 20 ml packs, which is stored in minus 30 degrees centigrade again, and it can be stored for 1 year. Then we have two types of platelets. Usually people get confused here that we have two types of platelets, which is used where and which can actually increase the platelet count more, right? We have random donor platelets and we have single donor platelets. Random donor platelets is less in volume, 50 to 70 ml. It is stored in 20 to 25 degrees Celsius, and we can store it for 5 days. Single donor platelets are high in volume, 200 to 300 ml, 20 to 24 degrees Celsius, and we can store it again for 5 days. Both are stored for 5 days, but there is difference in volume. So this difference in volume translates to the increase in the platelet count in the patient who has thrombocytopenia or in whom these platelets are actually transferred. So if you are going to transfer a less volume platelets, which is random donor platelets, obviously the hike in the platelet in the patient is going to be very less. So this can increase up to 10,000, right? But at the same time, when you are going to transfuse a volume of 200 to 300 ml of platelets, obviously the hike is going to be more, which is expected to be around 20 to 25,000 increase in the number of platelets. And there is one trivia about this, that since these are stored in room temperature, there are increased chances of bacterial contamination, and at the same time these can only be stored for 5 days. All right, hopefully this is clear, and this actually will help you understand that malaria can be transmitted through all of these blood products. Okay, moving forward. Now we are done with collection of the blood and storage of the blood. Now we move forward to the actual case scenario where we all doctors jump up. All right, so we are going to move forward to the transfusion. There are certain rules of transfusion that everyone should follow. All right, the time of all this rule begins from the time of issue of the blood from the blood bank. As soon as the blood at the blood bank, they are going to seal and they are going to sign and release the blood. The time actually starts at that point. Okay, so the transfusion must begin within 30 minutes of taking out from the fridge, and it should be completed within 4 hours. Right? The 4 hours actually starts from the time of issue. Always remember the time is going to be time of issue, not the time of starting. The time of start must be 30 minutes from the time of issue, and the time of ending must be within 4 hours. So there is something here that I always remember in a chain manner, right? I remember it as 17, 18, 19. 170 is the micron of the filter that can be used. 18 to 19G is the cannula. So you can use 18 to 19G cannula, you can use 170 micron filter, and you are supposed to start the transfusion within 30 minutes of taking out the blood product from the fridge, and it should be completed within 4 hours. Then we'll look into the complications, the so-called complications of transfusion. See, uh, there there is a very simple logic behind this. You can see everything. That's all I can say. Right? I'll explain you in a bit. You can see alkalosis. You can see acidosis. You can see hyperkalemia, but you can also see hypokalemia. You can see hypocalcemia. You can see hypothermia. You can see coagulation abnormality. It seems like you can see everything, all right? So let's take a deeper look into this. Alkalosis is found to be more than acidosis. Citrate toxicity is seen because, as we already saw here, all the anticoagulants have citrate, right, except the sagum. So if you're going to have a multiple transfusion or massive blood transfusion in a patient, you can actually load the patient up with citrate. Yes, so that can chelate with the calcium, leading to a hypocalcemic state in the patient. This hypocalcemic state in the patient will present as the tingling sensation, numbness around the mouth. That can lead to, in severe states, can lead to Chauvistic sign, uh, and all of that. Now, moving forward, you can see hyperkalemia and hypothermia. Why hypothermia? The blood is stored at 2 to 8 degree Celsius, as discussed above, 2 to 6 degrees Celsius, as discussed above, and that is actually going to cause hypothermia in the patient. Not only blood, you're seeing that we are storing things at minus 30 degrees Celsius, except platelet, everything is in a very low set of temperature, and that can actually cause hypothermia in the patient. And coagulation abnormalities can be seen in patient in that can present to you as DIC, which is disseminated intravascular coagulopathy, and these are few complications that we should know. Following which, we are coming to the main guys, TRALI and TACO. TRALI is transfusion related acute lung injury. This is caused in a patient due to anti-leukocyte antibody or antibodies against the HLA antigens, and this presents this is presented to us, or the patient presents to us within 6 hours of a transfusion, and presents with an ARDS like symptom where you are going to get a whiteout lung. And here, very distinctly, you can differentiate it from TACO on the basis of hypotension's presence, right? I'll explain that to you in a bit. Moving forward, we have TACO, transfusion associated cardiac overload. Here, it is caused due to the rapid transfusion of blood in a severely anemic patient. For example, a patient is already very anemic and you're going to transfuse, like you're going to give 4 units of blood in an hour, or you're going to replace the entire circulatory volume in a matter of 1 hour, 1 day. You're going to get cardiac overload in the patient that presents to you similar to heart failure, and this is actually treated with oxygen and diuretics. Now, TRALI and TACO both are presenting to you with a similar ARDS like symptom. Alright, both are going to present to you like ARDS. I'm not saying it is ARDS because TRALI is proper ARDS and TACO is going to be presenting as heart failure. But these are actually very confusing when it comes to a setting of a question based scenario. Alright, at that time you're going to look into the question. If you're going to find hypotension, it is more likely to be TRALI. When you're going to find hypertension and tachycardia, you can conclude it as a case of TACO. This is a simple trick that people usually follow. And here I forgot to mention that this hyperkalemia is the leading cause of arrhythmia in a patient. Alright. Now, moving forward, what is a massive blood transfusion? As already said, if you're going to replace the entire blood volume in a matter of 24 hours, or you're going to transfuse 10 units in 24 hours or more than 4 units in matter of 1 hour. It is called as massive blood transfusion, and you can expect uh, complications like tracho and trali. If in case you have found a complication, you're supposed to stop the blood and you're supposed to administer the patient with 1 vial of hydrocortisone, 1 vial of Avil or antihistamine. You're supposed to wait for 30 minutes and you have to restart the transfusion. All right. But in cases of severe anaphylaxis, you can consider other ways. But usually, this happens when patients have developed some allergic reactions. We give them a steroid, we give them an antihistamine. We are going to wait for 30 minutes to let the reaction subside, and then we are going to restart the transfusion. All right. Then, coming back to the last segment of this discussion, this is actually uh, a very close discussion to me because this was taught to me by one among my teachers only once and I never forgot it afterwards. So, looking into the vacutainers and order of draw. So, the first vacutainer that everyone must be familiar with, actually, there are a lot of vacutainers, but these five are supposed to be something that everyone should be aware of. All right. So, this is the red vacutainer, which has no anticoagulant, or usually it has clot activating factor. All right. It has clot activating factor in it. It is usually used for serological examinations because the blood gets clotted and you have the serum. And then you have the gray top tube. Gray top tube has sodium fluoride in it. It is usually used in, it's not usually, it's actually solely used for the purpose of glucose estimation. And how does it act? It acts by inhibiting enolase. This is something that is repeatedly like tested everywhere. And the lavender top tube, it has EDTA and it is used for hematological examination, ESR. It is also used in, very recently this has been asked, it is used in the calculation of A1C or HbA1c. Then we have sodium citrate tube. It is used for PT, APTT and coagulation studies. We'll look into the coagulation pathways in the upcoming videos. And then at last we have green top tube. It is heparin tube. It is used for bone marrow studies. Then we have order of draw. Why do we follow our order of draw? Is because we don't want the anticoagulant or the content of the tube to get mixed and cause reactions in the other tubes, right? So these are the 6 order of draw that everyone must be familiar with. Usually, you will be able to navigate through if you are going to know this. Since there are 6, there was once a teacher I had who told me that you have to split it into 3 and 3 and it will be very easy. So first we are going to get culture. We have blue tube and red tube. Then we have green, lavender, gray. Culture, blue, red, green, lavender and gray. It's culture, blue, red, green, lavender, gray. Right. So with that, we have come to the end of this discussion. Hopefully you were able to revise or able to remember what you had already studied or were able to learn something new out of this discussion. Signing off until next time.